So welcome everybody. Great pleasure to be here today and introduce that second session to a day with the Cochrane Grading Methods Group. And I'm this first guy here, first presentation for this 90-minute session, and I'll be speaking about, as Chris introduced, about great guidance for considering non-randomized studies. And for those of you who are not part of the first webinar, I work at McMaster University. The next slide is just going to show my disclosures. There is no direct financial conflicts of interest. I co-chair the Grade Working Group and co-convener of the Grading Methods Group, director of Cochrane Canada to intellectual conflicts, and several of the slides are borrowed from my graphically very talented colleague Carlos Coelho. And obviously, the work that I'm presenting is really the work of the Grade Working Group. However, the views expressed, so any opinions or interpretations may be my own. So today's talk is focusing on non-randomized studies. I'll just give an ultra brief intro to GRADE to put things in context with the expectation that many of you may be not as familiar with GRADE as others. I'll talk about non-randomized studies in GRADE, obviously, and the integration of non-randomized and randomized non-randomized studies and randomized controlled trials. And finally, when to look for non-randomized studies. Much of the work that I will be presenting is based on a paper that was part of the GRADE guidelines. It's paper number 18, published in the Journal of Clinical Epidemiology in 2018, and we've previously referred to the wonderful website that the Cochrane Training Group put together, where all of these papers are actually listed in and with an overview of what they are actually dealing with. But to just start you out, as a fundamental piece of a Cochrane intervention review is the summary of findings table, and that's one of the pieces of the review that the Cochrane Grading Methods Group has played a big role in creating. Summary of findings tables are mandatory in intervention reviews. They provide the backbone to identify intervention effects on certain outcomes quickly. They have demonstrated their value in randomized controlled trials, actually, in terms of accessibility and interpretation of the finding, as well as some speed to find information. They probably often alter the interpretation of findings as well once review authors look at them carefully, once they've put them together. And the summary of findings table, as you know, it's an abbreviated form of these evidence tables, list outcomes here. With the relevant information, a certainty rating, relative effects of the intervention, as well as absolute effects of the intervention. Obviously, all of that related to the PICO question that is typically here on top. And this is from one of our living Cochrane reviews, last version 2017. I'll go on. Just how do we, so just to reiterate, there's a certainty or quality rating here, 4 levels, very low, low, moderate, and high. The question is, how do we get to these ratings? And this is a graphical presentation of how GRADE actually works. It starts with a systematic review and a body of evidence, randomized controlled trials. Start with a rating, an initial certainty of the evidence or quality of the evidence. Rating, we use these terms interchangeably as high. Then there are 5 domains that can lead to downgrading the certainty of the evidence listed here: risk of bias, indirectness, imprecision, inconsistency, and publication bias. And at the end, this then leads to an overall rating of the certainty of the evidence that may be high, moderate, low, or very low. And non-randomized studies start with a rating that is typically low, and I will get to some of the guidance that explains for when this might be different. Started low, they are still assessed with regards to rating down domains. They are also assessed with domains that, in terms of domains that may lead to increasing the certainty of the evidence for a final rating that is here. Just quickly, if you think of this entire process, there's again the 5 factors that lead to rating down and 3 factors that lead to rating up. There has been quite a bit of confusion around the fact that, there has been quite a bit of confusion around the fact that we might be addressing risk of bias twice. One is by looking at the study design, so for instance, randomized versus non-randomized studies, and then again, when we look at the detailed risk of bias assessment in non-randomized studies. And this is just to clarify that there is one risk of bias domain, and randomization obviously addresses part of that risk of bias. Only the detailed assessment by studies is still necessary. And this is what this next slide shows. And the rest of my presentation will be very much focusing on integrating the risk of bias in non-randomized studies of intervention tool, also called Robbins I. With the arrival of the Robbins I tool, which this paper number 18 refers to, the risk of bias assessment has dramatically changed. It's changed in a way that the risk of bias domains that are addressed in this tool resemble or come closer to the risk of bias domains that are assessed in randomized controlled trials. Just take this more than hypothetical scenario where a systematic review would have addressed risk of bias in randomized controlled trials using the risk of bias tool, and non-randomized studies that have been identified using the Robbins I tool. And let's just assume that the investigators went out and did a meta-analysis for both of these bodies of evidence, the non-randomized study, the randomized studies, as well as the non-randomized studies. The big question that most people will ask is whether or not, at the end of the day, when we've assessed risk of bias, and if that risk of bias potentially was comparable, potentially, I'm saying, whether or not we should be bringing these type of bodies of evidence from randomized and non-randomized studies together in a pooled estimate, which is what this graph shows. It's not guidance, it's just what this graph actually shows. So that's the big question, right? And in a scenario like this, there may be somewhat less concern because the results look pretty similar in the randomized and the non-randomized studies. I'm just labeling this as an example. In a scenario like this, also from a review that addresses antithrombin replacement in patients with sepsis, if I remember correctly, in a scenario like this, where the randomized controlled trials show a quite different overall estimate of the effect from the non-randomized studies for the potential outcome, there may be much more concern about integrating these two pieces of evidence. Nevertheless, this is work by Carlos Coelho, who I mentioned already. Nevertheless, there are many investigators, many individuals who, this is based on a survey, or systematic review authors, who pool these type of results depending obviously on the kind of findings. This shows an overview based on a survey in about about 80 respondents that indicated that in many instances people do actually do this type of pooling. People provide randomized studies and non-randomized studies as a pooled estimate. A large proportion considers them separately. And as it regards summary of findings tables, about a quarter of the respondents here said that they would produce separate summary of findings tables. I'm sorry, that we would only list the studies by narratively without synthesizing them. Some would only synthesize in the meta-analysis, a randomized trial. So anyways, what I'm trying to indicate is lots of variation in terms of how people deal with it. Okay, good. So does Robbins I, the use of Robbins I, then actually help us? A few things that are noteworthy and that we are explaining in that paper is that when we are using Robbins I to assess the risk of bias in non-randomized studies, the initial certainty based on the comparability that is assumed when using Robin's I of non-randomized studies to a randomized trial. The initial certainty rating may be a high rating. However, what we are suggesting is that by default, non-randomized studies, if they present the body of evidence, that they are rated down by 2 levels to low, as our previous guidance suggested. However, that already poses one potential problem, and that is that our previous rating for risk of bias allowed rating down by only 2 levels. So for randomized trials, it would go down to a low rating. If we now use Robin's I, rating down by 2 level for risk of bias would allow us to only rate down to low certainty. That's a problem, and we've addressed it by saying, following Robin's I guidance and following great guidance, that rating down the certainty of the evidence when Robin's I is utilized allows rating down by 3 levels. And there's one of our papers that you find on the website that explains that it's actually an extremely serious level of rating the certainty of the evidence. I wanted to come back to the issue that I just described, which is really that issue around the measuring stick. When we typically use our risk of bias tool for randomized controlled trials and now have a risk of bias tool for non-randomized studies, Robin's I, how does this actually work? What we are talking about is that for risk of bias evaluation of randomized trials, we typically rate down by 2 levels. There is no 3rd level as of now, and probably there's not going to be one. However, when you use Robin's I, there's going to be rating down by 3 levels. Also, just in this context, to dig a little deeper with regards to the use of Robin's I, the bias in non-randomized studies with Robin's I is assessed on the basis of these 7 domains. The first 3 domains relate to or are compatible to or address basically the risk of bias that is avoided by the randomization process, primarily related to selection bias. But what you're looking at is in randomized trials, the way that randomization was actually done and whether or not there was allocation concealment. In non-randomized studies, you ask for risk of bias due to confounding, selection bias, and the classification of interventions. And you see that that differs between randomized studies and non-randomized studies, while the other 4 risk of bias domains in Robin's I are somewhat comparable. And what that basically means is that using Robin's I allows some sort of comparison against this ideal target randomized controlled trial. Come back to the example that I showed you a bit earlier with regards to how to bring studies together that resemble a body of evidence from randomized and non-randomized studies. So just quickly think back to the sepsis example that I to the first example that I provided you a bit earlier with. That was the example. So how would we now present this type of information in a summary of findings table or an evidence profile? Every summary of findings table should start with an evidence profile, which is a more detailed explanation, and a more detailed assessment of what ends up in a summary of findings table. So first of all, one way of presenting the information is to just say there's evidence from 19 randomized controlled trials. In this case, there was some concerns about inconsistency and imprecision. The overall certainty of the evidence is low. This is the point estimate for the relative effect, point estimate for the absolute effect with 95% confidence intervals. And reviewers, if they had included non-randomized studies, might as well add a second line and describe the evidence from the non-randomized studies. In theory, reviewers might say, well, these results are similar enough that we could actually bring them together. Now, GRADE has big concerns about doing this, and there's only very few scenarios where we suggest doing this. Our answer to this particular question of what information you should be presenting is that you should present in a summary of findings table or in an evidence profile the actual results from the studies that are utilized for decision making, which in this particular case probably would be the randomized controlled trials. You can put this information on non-randomized studies, and if anybody feels strongly not following great guidance and wants to provide pooled estimates, put this in the footnotes. So again, just to provide the suggested approach and put that paper in a summary, the key message is when you use Robbins I, not downgrading from high to low certainty, that is by 2 levels, requires a very transparent and detailed justification using the Robbins I tool in great detail. This should be done for all of the items of the Robbins I tool, and honestly, we have not identified any example for how to do this. Just a few extra points with regards to using Robbins I. So when you use, for instance, Grade Pro to do your evidence profile or your summary of findings table, and you identify observational studies as your underlying study design. There is a hint. If you use Robbins I, it leads to a different assessment. In other words, it allows that grading down by 3 levels for risk of bias, which is not the case for obviously randomized controlled trials or non-randomized studies, observational studies that do not use Robbins I. A couple of final key points. One of the big questions that we are facing in systematic reviews is, when is it worth to look for non-randomized studies? And it kind of provides an answer to this original question of whether or not you should even provide the evidence together. One way of thinking about the use of non-randomized studies is, what type of information do they really provide? We have previously put forward a framework that describes these non-randomized studies of interventions as complementary evidence, as sequential evidence, or replacement evidence. Replacement evidence, in a nutshell, is when you think that non-randomized studies of interventions trump, to use a not so nice term actually, well, anyways, trump the evidence that you obtain from randomized controlled trials for decision making. Complementary evidence is, for instance, informing estimates of baseline risk, or whether or not there may be effect modification. Sequential evidence, for instance, relates to long-term effects for certain outcomes. What we have now done, and this is a paper that is ready for submission by grade. What we have now done is provide guidance for when to look for non-randomized studies. So first of all, the first issue is it a question about an intervention? Because obviously for prognostic questions and other types of questions, non-randomized studies may be the right answer right from the start. We suggest doing a scoping review to understand whether or not RCTs are available. If they are available, or if you're uncertain, you would actually look for randomized controlled trials and start with that assessment or evaluation for the certainty of the evidence of randomized controlled trials first, and identify for an outcome the type of certainty that is there. If there's no randomized controlled trial, it's pretty obvious that in many instances you would actually look for non-randomized studies, and if they are available, use the non-randomized studies. There is a question, however, if there are randomized controlled trials, if non-randomized studies can provide the type of complementary, sequential, or replacement evidence. And the brief answer is that in general, that when there's high certainty evidence, there's no need to further consider non-randomized studies as replacement, complementary, or sequential evidence. When that is not the case, you need to be cautious. And what we are providing is a guide for when this might actually be how this graph can be implemented. So, for instance, here I'm thinking about the randomized studies and the non-randomized studies. When you have assessed the certainty of the evidence, once there for cells, for instance, A, B, C, and D, you would quickly realize once you have high certainty evidence from non-randomized studies, no reason to look for that type of evidence because what can happen, there's no way that the non-randomized studies can potentially trump the type of evidence or exceed the certainty of the evidence that the randomized trials provide. For moderate low or very low certainty, the scenario is a bit different. Still, when there's moderate certainty evidence, it is unlikely that non-randomized studies will actually make a difference, except for instance, if you have concerns about indirectness, and non-randomized studies may help you with indirectness ratings. Down to the very bottom here, when there's very low certainty from non-randomized studies, it may be very useful to look for evidence from randomized studies. It may be very useful to look for evidence from non-randomized studies. And that's really my brief overview of the use of non-randomized studies and the updates that we have for you from the GREAT working group in the context of systematic reviews, and how to think about them in the context of randomized controlled trials. Really nothing has changed in GREAT with regards to the assessment of non-randomized studies if Robbins I is not used, except for that guidance for when it might be useful to look for them that I showed on the previous two slides. If Robbins I is used, you start as high, but the default is rating down by 2 levels, unless there are really good reasons for not doing this. We really don't have any additional examples beyond our prior examples that led to rating up the certainty of the evidence. And one way of thinking about this is, rather than rating down and rating up again, you might avoid rating down, for instance, when there are very large effects at play. And I briefly describe when it is worth to look for non-randomized studies. This guidance will be coming to you in a very short period of time. Thank you very much.
Thanks, Holger. We've just got a minute or so for a very quick question before we move on to Gordon. So we've had a few questions through, but I'll take them in order. Maria Elena has asked, wouldn't we also try to subgroup separately the prospective and retrospective non-randomized studies, and perhaps the case controls and cohorts separately too? I'll put that into the chat.
Yeah, very quickly, Marilena, again, if Robbins I is utilized, then I think that issue is resolved. Again, we need to make sure that Robbins I guidance is provided for all appropriate studies. So a case control study may be retrospective. The risk of bias assessment on the individual domains would still take place in the same way as you might do it for cohort studies, but the initial study label would not have an impact on how we rate the certainty. And that is also not different from how we looked at it previously, where the different types of bias would have an impact on whether or not you rate down, regardless of if it's a prospective or a retrospective design.
Thanks, Holger. One quick more question from Becky. Becky asks, can you clarify why we would use Robbins I to downgrade 3 levels of certainty for a risk of bias when observational trials already start at low certainty because of the nature of the study design?
Okay, so just very quickly, that's the big difference that we now have. The big difference is when Robbins I, because of its fundamental principle that it is comparing risk of bias against an ideal randomized controlled trial, when Robbins I is utilized, the assessment of risk of bias differs. It fundamentally differs in that, in theory, that body of evidence starts as high certainty evidence. And it is clear that if you use that tool, if you decide to use that tool, you still need to be able to end up at very low certainty. If the risk of bias is so extreme on all of the domains, you might still end up at very low certainty. While previously, when we started at low certainty, rating down by 1 level for risk of bias and the detailed assessment would bring you to very low certainty. So we needed, in order to apply GREAT correctly, I would say, we needed to provide a solution for rating down by 3 levels when using Robbins I, which has a fundamentally different approach to assessing risk of bias, again, against an ideal randomized trial. That would be the brief answer.